through the lens of the COVID-19 pandemic. But the point you made just a moment ago is really relevant. These are pre-existing. The health and care sector is one which has got one of the greatest levels of risk to our workforce in terms of mental health burden. We work 24/7. We work through conflict. We work through trauma. We work through dealing with patients and communities who are experiencing loss, bereavement, tragedy. So our workers are already enduring these challenges, and the COVID pandemic was no different. We saw just in this morning's conversations the impact of conflict, the attacks on healthcare, the attacks on worker in situations of conflict where we're getting the same normal reaction. We have the physical, the mental injury, the moral injury that come there. So this is a challenge that every health and care system is facing worldwide at different levels accordingly. And if we come back to the theme of humanizing health, and we talk just on the posters we have in front of us, this conflict, equity and resilience, what are some of the options that we can do? The recommendations we put forward at global level in terms of trying to drive the agenda, recognize the problem, build some of the issues. But most importantly, what were the actions that could be done at national level? And that's where both Barcelona and Doha have been two of the world's demonstration sites to actually look at this in context, look at this in reality. And rather than talk about the global, I think we should really focus on the national. What's happening in countries, jurisdictions, hospitals to take forward this work?
Absolutely, which brings me nicely to Dr. Cindy. You're working on an initiative aimed at protecting healthcare professionals' mental health in collaboration with HMC, with WISH, with WHO, based on the 2022 Duty of Care report. Could you please provide us with some insights into this initiative and share some of the practical tools that are designed to safeguard mental health at both the organizational and individual levels within the hospital clinic where you are?
Thank you, Homara. Our project is based on the Duty of Care report, and at first we did a rapid review to analyze the prevalence of mood disorder, stress factors, or what kind of interventions the organizations have or offer to the health and care workforce. So our project is based in three specified points. No, the first one was our rapid review, and we found that we maintain this kind of level of increase of stress factors, mood disorder, and for example, recently in Spain we have the result from the Council of Nurses, the General Council in our country, about that almost 23% of our nurses want to quit to her job. No?
That's a really high figure. 23% of nurses want to quit their jobs.
And almost 20% of them want to get the medical leave related for burnout. Wow. So it's an increased level of mood disorder, mental disorder. So we have to do something. This is our duty of care, to try to do something for our health and care workforce. So this is the first point that we base our project. The second point is we identify a theoretical framework to try to guide to the healthcare organization how kind of intervention we can offer to our healthcare workforce. WHO has an important guide based on different kind of intervention, but not only individual intervention. They provide us two important or relevant intervention. For example, the organizational level intervention. This kind of intervention is very important because this intervention try to assess, mitigate, or eliminate risk factor associated with work environment. So this is the key to try to do something for improve, for maintain not only mental health, even well-being, but not only physical well-being, because well-being have two important things, no? Physical well-being and emotional well-being, no? Because mental health is try to detect early detection and to do prevention on mental health disorder. And the point number 3 in our project, no, is to design, to create a toolkit based on this. The findings, no, in our rapid review, the theoretical framework, and to try to identify different intervention for recommend to healthcare organization.
And I want to come back to you about how you measure all of those key things, actually.
Yes.
It's very interesting. But I would like to get to Ian. As the CEO of Mental Health Services at HMC and a collaborator on this initiative, what steps have you taken to ensure the implementation of the Our Duty of Care guidelines to protect the mental health of healthcare workers in Qatar?
Thank you, Mayor. I'd like to start by going back to the point that Jim was making, that what we learned during COVID, but as a result of what had gone before, was healthcare workers are predisposed to trauma, to burnout, etc. And that was brought into sharp relief when we experienced COVID-19 across the world. The reason we have this partnership is less to do with mental health and more to do with an initiative that was created within Hamad Medical Corporation. Our Chief of Resources, Ms. Fatima Haider, and our Chief of HR, Ms. Mona Hamedi, they introduced an initiative about staff well-being generally. And one of the reasons I mention that is because I think if we isolate mental health and think about the mental health of healthcare workers, we run the risk of excluding healthcare workers from receiving mental health support because of the stigma that surrounds mental health. So as a healthcare professional, I would have difficulty in expressing the fact that I might be suffering from stress or burnout. So the initiative that Human Resources has put together, and there's some of the team here now, has enabled us to integrate mental health and well-being with well-being generally. And I think that initiative in itself has helped us to propel some of the lessons that came from the Duty of Care report. And the collaboration with WHO, WISH and Barcelona, I think has allowed us to really take some learning from that experience, take learning from the COVID experience, and the example I would give, and it features in the Duty of Care report. One of the things that the country here in Qatar did was it created a national mental health helpline during COVID. And it created that helpline for the public, for healthcare workers, etc. And the use of that helpline by healthcare workers was really quite significant. But what it illustrated was that people were not seeking help because of COVID. They were seeking help because of the predisposed nature of the conditions that they were presenting with. So I think putting those things together and then starting to look at the review of reviews and some of the tools that are emerging from that gives us a very good chance of embedding some of these practices and dealing with the fundamental cause of stress and burnout within healthcare workers.
You mentioned two key things there, fundamental cause of stress and burnout, and also stigma. Do you think that still exists? And if so, how do we combat it?
Yes, it absolutely exists. If there were more time, I'll quickly tell you there's not time, but I often do an exercise where I'd ask an audience like this to stand up.
Right.
I'd ask
Do you want to do it now?
Have we got
Why
time?
not? Yeah, we've got time.
Can I ask everyone to stand up, please? Some people will have witnessed this before, others won't. Okay?
Don't know what I've let myself in for, but okay.
So what I want us all to be very, very honest with ourselves, okay? And the preface to what I'm going to do is to remind us all that 1 in 4 of us will suffer from some form of mental health disorder, distress, or will know someone who does. So here's a series of questions. I want you to sit down if you have never had difficulty sleeping? Sit down if you have never had a worry that prevents you from thinking about the thing that you're supposed to be doing at that time. Sit down if you've never felt really stressed after an incident on the road or when we've come close to an accident. I'll speed it up a bit. Sit down if you've never known anyone who you were worried about in terms of their mood. Sit down if you have never come across a member of your family that you felt might need some help with their mental health. Okay? Sit down if you discovered that you have a mental health problem, and maybe a serious mental health problem. Sit down if you would be frightened to discuss it with your boss.
Wow.
So the reason for using that in answer to Humaira's question is we all know someone who has suffered. Some of us may have suffered. We all understand that seeking help will help the fact that we've suffered, and yet the stigma and the prejudice and the worry of discussing it prevents us from doing so. So in answer to your question, yes, of course it still exists.
Thank you so much for
and
that
not only
interactive
that,
exercise.
but the evidence is very much there. So the one thing about COVID-19 is that it surfaced an awful lot of research and analysis into the impact on the health workforce, and that's continued beyond. So the review of review, 1 in 4, 1 in 3 was stress and anxiety, 1 in 3 with depression, 1 in 2, 1 in 3 with burnout. So the empirical data is there. What we're not seeing, though, is some of the issues around addressing stigma. We're still not seeing employers take responsibility for this. The burden is on the individual, when the duty of care is making it very clear that we need to put some of the responsibility, not all, but some of the responsibility onto the institutions and the employers to protect and safeguard workers against these risk factors.
But they will tell you that they do, and they will tell you that they will. So, what are the main critical barriers then in that case when it comes to implementing these recommendations and these policies? And then I'm going to open the floor for any audience questions, so get ready.
Well, that's one of the challenges, I think, is this ownership, one of the barriers, because the evidence is there, but that means employers have to take more responsibility to own this issue and say, it's all well and good to do a telephone helpline. It's wonderful to offer counseling. But if we're not addressing the lack of workers, if there's only one person or two people on a night shift, and that burden of responsibility is being transferred to that nurse who maybe has only just graduated 2 years prior, she's suddenly faced with a night shift where there's no clinical supervisor available, or a junior doctor just out of practice coming into a weekend shift, and there's no clinical supervision from the specialist. If we don't fix those problems, we're not removing the risk factors. And that's what Ian and Cindy are doing with their 2 hospitals to take some of that responsibility.
Yeah.
Very quickly, Dr. Cindy, and then you can respond, and then I'm going to open the questions to the floor.
I want to add that one barrier to implement or to take aware of the mental health problem that we have in our health and care workforce is the stigma. The stigma. For that reason, I think we have to do something for train the manager levels, for take awareness to the mental health disorder exists not only in our patients. I'm nursing coordinator at the psychiatry services at Hospital Clinic of Barcelona, and as a healthcare worker, we try to fight against the stigma to my patients, to teach them that the mental health condition are like a physical health condition, but sometimes we don't fight and gain our stigma, no, in front to the mental health, no. Have a mental health disorder, a mood disorder is like have diabetes or have hypertension, no. It's another disease. So we have to fight to our own stigma for mental health disorders. Yeah.
Okay, I'd like to open up the floor now for any questions that we may have in the audience. Is there anybody who would like to... Hassan, if we could bring the microphone here to the lady in burgundy. Thank you.
Hi, thank you for this. It's really important. And we talk about stigma all the time. We talk about stigma with students not being able to talk and speak out about how they feel. How do you feel about... Okay, let me start with mental health. Everything we do in mental health is one-on-one. You see your psychiatrist, you see your counselor, and then you walk away, and your emotions are still within you. And I believe that we need community to support individuals struggling. When an individual struggles, the entire family struggles. What do you think about emotional intelligence and really teaching people emotional intelligence to support one another? And I'd love to have a conversation with you separately on this. I don't want to take away your time, but we've created a program for emotional intelligence. I'm on the board of the D.D. Hirsch Mental Health Services in the United States. We're the second largest mental health services. And I started the program for students because like you said, like Jim Campbell said, young people go straight from university into the workplace, not just hospitals, but anywhere, and they don't know how to speak out. So let's teach them and give them these skills of emotional intelligence to go out there and speak out. But then organizations need to be emotionally intelligent qualified. So are we doing anything in that space?
Who'd like to answer that? Ian? Or Dr. Cindy?
Yeah, thank you. I think it is a lot of kind of intelligence. No, one of them is emotional intelligence, but no, each person don't have this kind of management for manage their own emotion. No, for that reason we have to train people on emotional intelligence in mental health issues, and we need to start for university. For that reason, we have to connect the health care organization with university and train our students in the degrees at the university in this kind of issues. How important is to take aware of your own emotion and manage your emotion, because then you go to work in a hospital with a lot of factors or a negative input for your life, and you have to be strong now because you receive your patient emotions, the relative emotion, and you have your own emotional area, social area, familiar area. You have a lot of problems, not only the work problems. So for that reason, I think it's very essential to consider to train our students at the university. Yes.
Yeah, a lot to get into. I have another question at the front here, please, Hassan. Lady in the white jacket. Hello.
Leadership is very important. What is the role of leadership in implementing programs and protecting the mental health of healthcare workers at organization, and how can other organizations learn from your project and your experience in protecting mental health of healthcare workers?
So the question is about leadership. How can they learn and implement what you're recommending?
Okay, thank you, Sana. I think just linking back to the previous question about individuals and how you support individuals, I think the most important objective for leadership is to normalise the conversation around mental health. Give supportive leadership. Make it okay for me to tell my boss that I'm not feeling so great today. And as part of the tools that have been developed and some of the work that's been done within HMC, it is about training leaders. It is about trying to make the system more resilient. It is about trying to understand firsthand from healthcare workers what matters to them. And I think leadership need to listen. I actually picked this experience up when I was in Barcelona. We were introduced to a group of staff who were talking about their experience in COVID, and they were extremely traumatized. And when they were asked one of the things that you would choose to have done, they said, just be listened to. A leader can't take away the trauma. A leader can't take away the event that occurred before, but the leader can listen and seek to help the person process their experience. So I think the role of leadership is to become much more aware, help to normalize mental health within the workplace, and listen to people.
Thank you so much, Ian. Just to pick up on your point very briefly, and then we'll come to you, Jim. Leadership, yes, need to listen, and they need to be aware, but how do we actually make that happen? How do you enforce it? Because it's not happening. So
I think that's a really good challenge. I think you start by the commitment, and again, if I use HMC and the work that our HRP colleagues have done, it's to try and institutionalize the behavior, and I think that commitment starts. The culture then needs to catch up with that commitment, and that does take time. But I would advocate to any leaders in this room, and there are a few from HMC, we need to, walk the talk. We need to be out there actively listening and make examples of good behavior. So if when somebody is feeling, burnt out, traumatized, create opportunities for those people to talk. So the honest answer is it's extremely difficult, but I think you start with the intention and then seek to change the culture towards that intention.
Thank you.
The one thing I would add there, just to make sure, everyone has a responsibility for leadership. It is not the job title or the position in the hierarchy to surface these issues and talk about it. I mean, we have the Young Nurse Leaders Group here that Wish has been supporting for many, many years. We have 155,000 nurse leaders around the world being supported to have voice, to have agency, to stand up. Around the world, 80 to 90% of that nursing leadership are women in the workforce. There's a session tomorrow on the role of women in the workforce. Everyone has a responsibility. It's not just a job title, whether you're in academia, whether you're in clinicians, whether you're in service, regulatory, stand up and enable conversations. It's okay. We can all say it. It's okay that if you're not okay. It's okay to have these conversations and challenge your internal hierarchical leadership to open up through your own voice and agency. Thank you.
Do you think it's a regional issue? Or do you think it's global?
The mental health burden and the way that institutions tend to react is a global issue. What there is definitely, there is context, cultural specific responses around how is it, can we surface this issue? In patriarchal, male-dominated, sort of masculine societies, we can't put our hands up and say, I'm not well. In other societies, there's different interpretations around weakness. To actually say, it's not because I'm not resilient. People have a normal reaction to COVID-19, the burden of stress. It was normal to feel stressed, anxious, and burnt out. That was normal. And we should be able to say, I'm not coping with this stress. But yes, it's definitely context specific.
Yeah, I would say it's global, but just picking up what Jim said, if there was anything positive that came from COVID, it was the fact it allowed people to say, I feel really anxious. The taboo was broken because, that wasn't a sign of weakness, that was a sign of normality. And it's how we capitalize on that openness of people, because if you address your anxiety, you get stronger. So I think it's global, but it's also contextual in terms of experience.
For example, in our project, we are working in different areas of opportunity for recommend to the healthcare organization how to guide their staff. And one of these section of areas of opportunity is leadership, as to try to show the organization what type of intervention for leaders are very important to implement in the different institutions, for to train, for to try to listen our staff, and for to give some first aids on mental health. For example, I have a background on mental health, and for me, it's easier to share time with my staff.
Okay, thank you. Sorry to cut you off there, but I'm very aware that I only have 2 minutes, and we've got a lady in the nice fuchsia jacket over here. Hassan, if we could pass the mic to her. Thank you.
Thank you very much. Very interesting discussion and very important topic. We are always, emphasizing the health workforce, but as an
If you could speak into the mic, please. Thank you.
as an academic person,
Yes.
also I would love, to have whatever you said to be applied for students.
Yeah.
We have to start from there
Yes.
in order to invest more in the time and the quality of work in the future.
Yes.
They will be the leader, and they will take care also of of those who are, older than them in the future.
Yes.
Thank
Yes.
you.
Yes.
Thank you so much. Is there any other questions from the audience? No? Any closing thoughts?
So, to everyone, the purpose of the World Innovation Summit for Health, the partnership with WHO, is to bring evidence into this policy dialogue space. But then it's for all of us to take that data and, having listened, having heard, to go out and put this into action in the national settings. The tools are there. We know what the risk factors are. We know what interventions are starting to have success. It is the responsibility of an employer as well as the individual. It is the responsibility of education systems as well as employers. And everyone, please, make sure that when you go home, convey this message, that we all have a joint leadership role to surface this issue.
Thank you so much.
I would add to that by saying you can become, Jim made the point earlier that leadership doesn't come from the top, leadership comes from within. You can be the message carriers. And one of the things that we've, as part of our mental health campaign in Qatar, we run under the banner, "Are you okay?" And the reason we do that is if I say to Hamira, "How are you?" invariably she'll say, "Alhamdulillah, I'm fine." But if I say, "Hamira, are you okay?" it opens up a conversation that she can then talk. So my request to all of us is to exert some leadership by looking to our colleagues, our friends and our families and checking that they're okay in order to help them to talk about some of the issues that we all might face at times. So thank you.
Thank you. Thank you to all our panelists for your invaluable insights and recommendations and sharing your time with us, and to the audience for your questions. Thank you very much.